Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient comes to clinic saying, "Doctor, I see double, especially when I look to one side, and it is worse when I look at something far away." The key question is this an ocular muscle problem, a cranial nerve palsy, a brainstem lesion, or a neuromuscular junction disorder? Sixth cranial nerve palsy means dysfunction of the abducens nerve. The abducens nerve supplies one muscle, the ipsilateral lateral rectus. The lateral rectus abducts the eye, meaning it moves the eye outwards. So when the sixth nerve is weak, the affected eye cannot abduct properly. The unopposed medial rectus pulls the eye inwards, producing esotropia, and the patient develops horizontal diplopia. Understand this is: sixth nerve lesion leads to lateral rectus weakness, which leads to impaired abduction, which leads to horizontal separation of images. That is why patients complain that the double vision is side by side, rather than one image being above the other. The diplopia is usually worse when the patient looks towards the affected side. For example, if the right sixth nerve is affected, the right lateral rectus is weak, so right gaze becomes difficult. The right eye fails to abduct, and the diplopia becomes more obvious. It is also often worse for distance vision than near vision, because looking at distant objects requires the eyes to remain more parallel. A useful clinical clue is the head posture. Patients may turn their head towards the affected side to reduce diplopia. This brings the eyes away from the field of maximal weakness and helps them maintain single vision. Now, the reason sixth nerve palsy is so important in MRCP is its long anatomical course. The nerve starts in the pons, then travels through the subarachnoid space along the clivus, passes through Dorello canal at the petrous apex, then enters the cavernous sinus, and finally reaches the orbit through the superior orbital fissure. A long course means many possible lesion sites. Think of the lesion sites in 5 boxes: pons, subarachnoid space and clivus, petrous apex and Dorello canal, cavernous sinus, and orbit. If the lesion is in the pons, think about stroke, multiple sclerosis, or tumor. A pontine sixth nerve palsy is often not isolated. There may be facial weakness, gaze palsy, long track signs, or other brainstem features. MRCP trap: an isolated-looking diplopia with limb weakness or facial weakness is not a simple microvascular palsy. It is a brainstem syndrome until proven otherwise. If the lesion is in the subarachnoid space or along the clivus, think about raised intracranial pressure, meningitis, subarachnoid hemorrhage, trauma, or clival pathology. The sixth nerve is vulnerable to stretch because of its long intracranial course. This is why raised intracranial pressure can produce a sixth nerve palsy, sometimes as a false localizing sign. The lesion may not be at the sixth nerve nucleus itself. The nerve is being stretched along its path. At the petrous apex and Dorello canal, the nerve passes through a tight anatomical space, so compression matters. Causes include petrous apicitus, skull base fracture, or tumor. The classic syndrome to remember is Gradenigo syndrome, sixth nerve palsy, facial pain due to trigeminal involvement, and otitis media. So if the exam gives ear infection plus facial pain plus diplopia, think petrous apicitus affecting the sixth nerve. In the cavernous sinus, sixth nerve palsy often comes with neighbors. The cavernous sinus contains cranial nerves 3, 4, V1, V2, and the sympathetic fibers, with the sixth nerve running close to the internal carotid artery. So cavernous sinus disease may produce sixth nerve palsy plus ptosis, ophthalmoplegia, sensory loss over the forehead or cheek, Horner syndrome, or severe orbital pain. Causes include cavernous sinus thrombosis, aneurysm, pituitary apoplexy, and Tolosa-Hunt syndrome. The key clue is multiple cranial nerves with painful ophthalmoplegia should make you think of the cavernous sinus. At the orbital or superior orbital fissure level, think about orbital tumor, inflammation, trauma, thyroid eye disease, or other orbital pathology. Here, diplopia may be associated with proptosis, optic nerve signs, pain, or restriction of eye movements from mechanical disease rather than pure nerve weakness. Clinically, the examination finding is failure of abduction of the affected eye. In primary gaze, there may be esotropia if the palsy is significant. The patient reports horizontal diplopia, worse on gaze towards the affected side, and usually worse at distance. Do not confuse this with third nerve palsy, where there may be ptosis, a down and out eye, and possibly pupil involvement. Do not confuse it with fourth nerve palsy, where vertical diplopia and difficulty going downstairs are more typical. The diagnostic approach is to localize first. Ask, is this an isolated sixth nerve palsy, multiple cranial neuropathies, or part of a brainstem syndrome? That single step guides urgency and investigation. Urgent same-day assessment is needed if new diplopia is associated with headache, ocular pain, papilloedema, ptosis, pupil abnormality, other neurological signs, trauma, cancer features, infection features, or fatigability. Fatigability matters because myasthenia gravis can mimic almost any pattern of ocular motor weakness. MRI of the brain and orbits, with vascular imaging where appropriate, is usually required if the presentation is atypical, young, progressive, recurrent, bilateral, non-isolated, or not improving. In older patients with vascular risk factors, a truly isolated sixth nerve palsy may be microvascular, but this is a diagnosis that requires careful clinical judgment and follow-up. Management has two parts: treat the cause and manage the diplopia. If there is raised intracranial pressure, infection, inflammation, stroke, tumor, cavernous sinus disease, or trauma, treatment is directed at that underlying condition. For symptoms, occlusion or patching can help immediately. Fresnel prisms may reduce diplopia during recovery. Botulinum toxin or strabismus surgery may be considered if the palsy persists. For an isolated presumed microvascular sixth nerve palsy, optimize blood pressure, diabetes, and lipids, and observe for recovery over months. MRCP trap. Do not label it microvascular if there are red flags, other cranial nerves involved, papilloedema, severe pain, progression, recurrence, bilateral involvement, or failure to improve. If you remember one thing, remember this: sixth nerve palsy causes impaired abduction and horizontal diplopia, but the real exam skill is localization. A long sixth nerve course means lesions can occur from the pons all the way to the orbit, and associated signs tell you where the problem is. Quick recall. A patient has horizontal diplopia worse on looking to the right. The right eye fails to abduct, and there are no other neurological signs. Which muscle is weak and which cranial nerve is affected? The answer is the right lateral rectus, supplied by the right sixth cranial nerve, the abducens nerve. A patient with recent otitis media develops facial pain and horizontal diplopia due to impaired abduction. What syndrome should you think of, and where is the sixth nerve being affected? The answer is Gradenigo syndrome, due to petrous apicitis affecting the sixth nerve around the petrous apex or Dorello canal. Do subscribe to the channel for further videos.